Well, welcome back to another episode of The Compass. I'm here with Brad Robison, MD, and today we are tackling how to navigate depression, antidepressant medicines. This is one of the things, Dr. Brad, that is trending in the zeitgeist of cultural conversations right now. And
Yeah.
one of the things that people rely on are people like you, medical
Mhm.
professionals who, in the day in and day out, are dealing with this. So I'm
Yeah.
wondering if you can just share for a second, just the overview of what is depression, and then talk through what is that criteria to actually, get a diagnosis where it warrants being put on this medicine. And then there's conversations about addiction and things like that that need to be
Right.
covered as well.
Yes, absolutely. Yeah, and man, it's a big topic in some ways, and we're so I just want to let people know right off the bat, we're probably just going to scratch the surface on a lot of things, but like that's a great opening question, is just to talk about depression. And I
Mhm.
think the concept of depression, everybody understands, and everybody has sad or depressed moods at times. And that's not really what we're talking about. We're not talking about just kind of normal sad moods. We're not talking about just grief. I mean, not just grief. It's not a great way of saying that, but because grief can be very, powerful, and but there's aspects of grief that are very normal to the human experience. But when we're talking about depression clinically, we're talking about something that's called major depressive disorder.
Mhm.
And we're talking about a pattern of symptoms that has predictive value for course and prognosis. And that's, no different than a lot of other diagnoses in healthcare in general. What is hypertension, or what
Mhm.
is essential hypertension? Well, everybody's got a blood pressure. Nobody argues that a blood pressure is, of 220 over 160 is a medical emergency and needs treatment. But what do you do with a blood pressure of 145 over 85 or 150 over 90? And
Yeah.
so the cardiologists have gotten together and looked at and said, well, okay, here's some criteria, and we're going to call this a disorder because it has predictive value about course and prognosis for the
Yeah.
individual. That if you meet these criteria, you're at significantly higher risk for a bad outcome down the road. And that's kind of what major depression is. It's not normal sadness. It's a set of criteria and symptoms that if you meet those criteria and symptoms over a span of a week to 2 weeks, I mean, I think the latest version is 2 weeks, but it's got to be persistent. Then that has predictive value in terms of negative outcomes, including suicide. I mean, and that's one of the things when we're talking
Yeah.
about depression that we have to keep in mind that, and of course, there could be a long conversation and debate about cultural factors and things that are involved, but, suicide for years has always ranked up there in the top 1, 2, or 3, depending on the age group that you're looking at,
Mhm.
causes of death. And so this cluster of symptoms really is predictive for a course that has significant morbidity and mortality, a significant, morbidity in terms of decreasing overall functioning, and mortality, obviously. So that's just a very, very quick overview of, some elements of depression.
Yeah, I think when I think of depression and people that are dealing with it, a lot of times I think about people who are also dealing with anxiety. How often is that the case? And then just from a practitioner, how do you decide when it is the right case for somebody to be put on medicine? What's the length of time that they should be on that medicine? And then, how do you help them just navigate in the middle of that?
Yeah. Well, anxiety is certainly so. Emotions, as we all know, our emotions tend to fluctuate and overlap a lot. We can feel sad and we can feel anxious kind of at the same time. But we're definitely talking about something that is a set of criteria symptoms that predicts the course and prognosis, as I just said. And there are clear, distinct criterion symptoms that have a predictive value of the course and prognosis for an anxiety disorder, if that makes sense.
Mm-hmm.
And that course and prognosis is different than a major depressive disorder. But people that are depressed with major depression certainly may have some underlying anxiety, and we end up, figuring that out and trying to sort out how to treat it. And then when you talk about, a treatment plan, when do you decide about medicines and when do you think about various aspects of a treatment plan? Well, that's when we really are looking at, our interventions and research. I mean, it seems like these days we've gotten away from, or people distrust a lot of research, and I kind of get that in a sense, but we don't want to throw the baby out with the bathwater, as the old saying goes. There's things that are really important in well done research,
Peer
and
reviewed, and
exactly,
understanding where the funding for these things are coming from,
right.
those are kind of important things to look at.
Exactly. And so, and these are things that have been like the treatment plan for major depression is not a new thing. It's things that have been researched repeatedly for a few, 2 to 3 decades in some ways. So there's actually a fair amount of research on this. And what the research shows is that a combination, and we can parse it out, but again, just giving everybody a quick overview, a combination intervention that really looks at some therapy, whether it's cognitive behavioral therapy, has been probably the most researched approach to major depression, cognitive behavioral therapy, or other types of therapy that have been evidence-based, shown to be effective for depression. I mean, DBT, IFS are some modalities that I tend to use that have developed increasing evidence base for various, things. But the point being that it's not immediately go to medications. There's a place for therapy and then a place for medications. And a lot of times for those people that truly meet that criteria for the major depressive disorder and that have that predictive value for significant morbidity and mortality, those individuals typically do better and are at lower risk for suicide if they're in a combination of medicines and psychotherapy treatments. So that's how I would in general look at it. And then of course people will ask, and they should, people ask because there's black box warnings and things on a lot of antidepressants, especially in young adults, of like, suicidality.
Yeah.
And, the data on that is something to be aware of. But again, what I think a lot of people I see at my office that are grappling with that sometimes miss is the idea that we're comparing risk of being on the medicines with zero risk.
Yeah.
And if we've done a good diagnostic evaluation and we're not just treating normal sadness, but we really are treating a major depressive disorder, then there's significant risk for morbidity and mortality. There's significant suicidal risk for that individual. And so we're comparing risk versus risk. It's not risk versus no risk.
Right.
And for the vast majority of individuals, the risks of treatment, including the risk of treatment with a medication, significantly outweighs the risks of not treating with a medication. And so those are some factors that have to be, looked into or considered. And you need a good, you need a good clinician that you trust to help you sort that out, and that is willing to listen to you and your family about what your concerns are. As I always tell my patients, I mean, I'm, like, that's my job, is to be the expert in these diagnosis and treatment plans, but you're the expert in you, so I'm here to listen. I'm here to help you really sort out the risk benefit ratio of any treatment plan.
Mhm.
And figure out what really makes sense for you or your family member. So
What populations do you think are at highest risk for suicide? Is it people that are been dealing with depression for 3 years? Is it somebody who's dealing with a short-term crisis and doesn't have coping skills? Is it a blend of both? It's hard to say the percentage to each.
it's a blend of both. There's certainly some data, and I don't, off the top of my head, I don't remember the exact numbers, but there's some data indicating like the percentage of suicide attempts in various age populations that are acute stressor related. But then when you go back and look, there's a really high percentage of those individuals that, even if they haven't been diagnosed, really did meet the criteria for a major depressive disorder at some point. So, meaning that most of the time, if you're not struggling with major depression and you have an acute stressor, the vast majority of people, they may feel down, sad, or, overwhelmed, but they aren't suicidal or don't follow through with, suicide or suicide, completion. Now, we could really parse that out, and maybe that's a whole nother video, but we could really parse that out for different age groups. So like right now, this time of year, of course, we deal with, children and adolescents, and, suicide rates are high amongst adolescents. And suicide attempt rates are high. Suicide completion rates are also high. Fortunately, not as high as attempts. But at this time of year, there's data, and my clinical experience is that the highest risk in our region is middle to older age farmers. They're the ones that haven't ever come into treatment. And, because of cultural things or, whatever, haven't ever come into treatment. Doesn't mean they don't have depression. They probably have had significant depression, but they're not coming into treatment. Those are the ones that are the highest risk,
Wow.
in our area.
Do you have a hypothesis as to why? I was instantly thinking this time of the year, harvest is kind of done. They're maybe, they're waiting on see what their yields could be. They've
Yeah, I think
been in the grind 12 hours a day for 7 days a week for 5 months, and that's now coming to a halt, and the rhythm's changed.
Yep. It's all of that. It's the stressors of the farm cycle and the farm season, and the high stakes gamble that farming is every year. If you win, then great, it's profitable, but it's a high stakes gamble every year, and this year's not looking good for anybody in the farming community. And so that's not new data. Like I said, I didn't prepare specific data, but like farming as an occupation has ranked, one of the highest suicide rates. Doctors is also a pretty high one as well. But farmers have ranked high in terms of occupations with suicide rates for a long time.
People at this time of the year also deal with the holidays, family dysfunctions. Do you see a lot of that in the clinic? And are these people that would be eligible for 2 or 3 months to come on some antidepressant and then come off? And then what is that when they come off? Are there withdrawal symptoms? And how is that process?
Yeah, great. Yes, I mean, they're definitely this time of year. Partly it may be related to the holidays, but there really is a pattern of seasonal, major depressive disorder with a seasonal pattern. And so when things kind of get darker and days are shorter and the holiday stressors, sometimes people really meet that criteria. I mean, it's not uncommon that people may get a little sad or down or blue, but that's not the population we're talking about. We're talking about people that meet that criteria for, that predicts morbidity and mortality. And those individuals do many times benefit. I have a lot of patients that go on an antidepressant during the winter months and then go off of it in the spring and do just fine. And then that leads to this question too about like, how long should you take the antidepressants in general? And most of the time, if you've just had one episode of major depression, the general consensus amongst the research and clinicians is that the majority of people, probably 70% or more, can go off of their antidepressants. We usually recommend 6 months. I sometimes say a year. Like I don't like to go off medicines this time of year. Like I would prefer to go off medicines in the spring. People just seem to do better, probably because of some of the seasonal pattern. And so, but 6 months to a year, and then taper off the medicines, and probably 70 to 80% of people do just fine, don't ever have another episode of major depression. But if you've had a second episode of major depression, then it flip-flops, the data flip-flops, where people that have 2 or more episodes of depression are at increased risk of having recurrence of depression. And those individuals tend to do better on maintenance treatment with the antidepressant. You just maintain the antidepressant and they are at significantly lower risk of the major depressed episode returning. And so those individuals at times stay on the medicine longer term. Now, we here at our office will work with the patient, and if at some point they want to give it a try, we'll plan a trial off medicines and see how they do. We'll agree on our early warning signs. We'll agree on like, okay, well, what are we watching for that's going to be your early warning sign that, things are going south. And we'll agree on that, and then we'll monitor it together. And then if they get to a point where they feel like they're going back into a major depressive episode, then we'll talk about, getting back on medications. They're not addictive. I get that question from time to time. Some people confuse that and what does an actual addiction mean? It's like, well, for a type 1 diabetic, is insulin addictive? Well, if you define addiction as like a medicine that they have to take, that they're dependent on, they have to take it, then yeah, I guess you could say that's addictive. But is it really? No, it's not. It's that their pancreas doesn't produce insulin, and they have to take it to treat the illness. And that's the same thing with the depression. For individuals that have recurrent depression, they do tend to do better to stay on maintenance treatment. Doesn't mean they're addicted to the antidepressants. And really, I mean, you can find all kinds of stuff on the internet about all kinds of horrible, crazy withdrawal symptoms, but that's exceedingly rare. I mean, people may get a little cold and flu, achy symptoms with some of the antidepressants. Venlafaxine is the worst. I mean, that withdrawal can definitely be uncomfortable if you abruptly stop venlafaxine. But they're uncomfortable. They're not unsafe or dangerous. They're not like an opiate withdrawal. They're not like a benzodiazepine withdrawal. They're not. People aren't having seizures and having life-threatening complications, and so the antidepressants aren't addictive in that way. And there's really not any data. The other kind of definition of addiction, again, I'm just hitting the highlights, but the other definition of a dependency is physiologically, if there's a tolerance that's building up to where you have to take higher and higher and higher and higher doses
Mhm.
with less and less and less and less return. Now,
Mm.
sometimes with antidepressants, we have to make dosing adjustments and all that, but it doesn't really follow the pattern of like an opioid, for example, where there's this tolerance and this just spiking, higher and higher doses and getting smaller and smaller returns. So with the antidepressants, you don't really see that. And then the other, that's dependency. And then the other just very good, quick definition of abuse, substance abuse, is continued use in the face of obvious negative consequences.
Mm.
So people can abuse a lot of things. I mean, we're just in probably an epidemic level of abusing electronics and social media, where we're seeing continued use in the face of obvious negative consequences. And we don't see that with antidepressants. I mean, we're not seeing that they're just like, I've got to have my antidepressant, and their functioning levels going, down and down and down and down, and they're, but I've got it just doesn't follow that pattern, if that makes sense. So on several fronts, they're not addictive or abused medicines in that regard.
Mhm.
Again, it's kind of like insulin. It's like, type 2 diabetes is almost a better even analogy of that issue, right? Type 2 diabetes is somebody who has developed insulin resistance and may need to be on insulin. But if they work really hard at controlling their diet and losing weight and exercising regularly, they may get to a point that they can get off of their insulin.
Mhm.
Well, were they abusing insulin? Well, I mean, you see what I mean? It creates a little bit of a gray area in that I would say no, they weren't abusing, their insulin. If they've had developed insulin resistance for whatever reason, and they are struggling with their weight and their blood sugars are 400 or 500, and they're, well, they need to be on insulin, and they're not abusing it in any way of talking about like dependency and abuse, like I was just describing. They're not using it in the face of obvious increasing negative consequences from the use. But if they work really hard at other factors, they might be able to get off of their insulin. So,
I I have another question too about just lifestyle.
yeah.
There's other things that somebody could do, because I see a lot of studies. I found this study. I put it on the screen for just a second.
Yeah.
It just says the effect of exercise for depression, a systematic review and network meta-analysis. And then you can kind of, scroll down to see the conclusion. It says exercise is an effective treatment for depression,
Absolutely.
particularly when intense. And
Yes.
on Instagram, kind of like what I see all the time are posts that are like exercise best treatment for depression and stuff like that. So
Yeah.
I wanted you to maybe speak about that, the lifestyle factors that somebody could have that improves or decreases their tenure with this thing they're dealing with.
That's a great article, and that's a great thing to bring up, even in the like connection to kind of the analogy and the similarities between true major depressive disorder. I mean, it is a set of symptoms that has really clear predictive value for morbidity and mortality, just like type 2 diabetes. And yes, exercise is hugely helpful. I mean, we preach it all the time here, more and more. I've talked about it for years, but I think it really, until the last 10 years or so, I was sort of like a lot of doctors. I think I was just giving lip service to it. But within the last 10 years, I tell people all the time, look, I mean, this isn't just like it's a good idea. Like it's, some sort of just general wisdom, like, yeah, exercising's good for you, or walking the dog around the block is good for you. No, it's not that. There is increasing evidence-based research that suggests that as it said, vigorous exercise, a commitment to a vigorous exercise regimen is a treatment. Like, it is an effective treatment for depression and type 2 diabetes, and actually a host of other things. It's one of the only things, there's been some studies in the last few years that have come out that I've said, maybe have said in one of our videos before. I tell patients here at the office, look, some of the studies that have come out recently, if some drug company could bottle it and sell it, we would be hearing about it globally as the absolute medical miracle, because it's the only thing in well done research studies that have been shown to reduce your mortality rates from all causes. Like, it dramatically reduces your mortality rate from all causes. So it's, yeah, exercise. I mean, we preach it to the point that my patients are sick of it. I mean, they're like, we'll have a conversation, we'll be talking about a bunch of things, and then I'll be like, well, and they're like, yeah, I know, I need to be exercising more. I'm like, yeah, you do. I mean,
most of the people that I know that have highly regimented exercise routines, I'll ask them about it. Like, I have a friend, he ran a half marathon every day for over a year.
yeah.
He still runs a mile no matter what. No, he travels all over the world. He runs a mile every day no matter what.
Yeah.
And that's a difficult challenge. And so I asked him about it. He's like, just for me, I have to do it. Like,
yes.
just I have to do it. And there's a lot of people like that. They're like, if I don't do it, then I'm not who I'm supposed to be. And it's good they recognize that.
Mm-hmm.
So I thought that was an interesting point to kind of add on to this. Are there any kind of final things that you wanted to hit or cover on this topic of navigating depression, antidepressants, and the journey that people are on?
No, I think we've covered most of the things that I felt like was maybe important for us to just real quickly hit on here for folks. Maybe the backdrop behind this that we've already hit on is just, be careful about the internet. Make sure you really are, if you're going to kind of go down rabbit holes on the internet, or you're going to really look for well done research studies, and really work to understand what that actually means. We're talking about peer-reviewed research that is really got a good control comparator to a treatment arm with good follow-up, and you're really looking at outcomes. And so and in some ways it means, even if you really want to dive into it, it means learning a little bit about statistics and some things like that. So that's one of the backdrops. And then another backdrop to that is finding a good clinician that you trust, because that's, in some ways, that's my job, is to go through all that research and be the expert in that, so you can be the expert in you.
Which brings up our next point. If you're interested or need to make an appointment, you can call 573-334-7055. You can also visit us online, Brad Robison, MD. We have a lot of resources. In fact, these videos are cataloged along with some other articles and things like that over on part of the website called The Compass. And so we invite you to go check that out as well. Thank you for tuning in for another episode